Hey guys, welcome back. The topic that we're going to study now is valvular aortic stenosis. This condition will usually be found either in pediatric age group or would be found in geriatric age group due to senile calcification and degenerative changes that would be occurring in the valve. So this disease is unlikely to be found in middle age or in people in their 20s or 30s or 40s. And what I'm doing at the moment is just zooming in into this image, which is an intraoperative image where you can notice the whitish deposits of calcification and there is a concomitant distortion of the valve. And since there's going to be difficulty in opening this rigid calcified valve, so therefore the left ventricle will develop a concentric hypertrophy, and therefore a lot of these patients would be having subendocardial ischemia and development of chest pain. What I've also done here is hand drawn before you a normal tricuspid aortic valve and then compare this with the malformed valve that I have here shown. The reason why this is malformed is because of activation of the osteoclasts. There is obviously initially a presence of fibrosis because it may occur even with rheumatic etiology. You very well know the fact that in rheumatic etiology it's mitral valve followed by aortic valve. So yes, I mentioned the fibrosis component, and then in old age there can definitely be calcification, and also since I mentioned that this could be pediatric presentation, so it can be congenital as well. Therefore, we can incorporate a question right in the beginning. If the question talks about the commonest congenital heart disease, you all know the answer. That would be a perimembranous variety of a VSD. But what I am mentioning here was a question in the exam that said, what is the most common congenital valve lesion that you see in a patient? Then the answer would be bicuspid aortic valve, and that's going to be responsible for aortic stenosis per se. So let's have a look at the various causes why it would be developing, though I have given you an insight that this would mostly be found in pediatric and geriatric age groups. So I'm going to just jot that information down. The first cause would be a bicuspid aortic valve, and no big deal. If it's going to be unicuspid, then there will even be more difficulty in opening this stiff and a rigid defective dysplastic valve, as a result of which the left ventricular hypertrophy will be substantial. Cause number 2 will be found in old age group, and in old age group you anyway know that atherosclerosis can also be present. So no big deal that you could be having triple vessel disease present in the patient, and along with triple vessel disease due to fixed obstructions in multiple coronary arteries, there is anyway episodes of chest pain, and because of the degenerative valve per se which is going to obstruct the exit of blood, again there will be a concentric hypertrophy, so the chest pain of this person will worsen. In fact, I want to tell you that Arnold Schwarzenegger, the Terminator guy, had developed because of he was Mr. World, and then subsequently he became governor in America, and obviously a very famous film personality with that famous dialogue, "I will be back." So he, in spite of having a very healthy lifestyle, he definitely ended up with CAD, coronary artery disease, and he also developed valvular aortic stenosis, for which transfemoral approach was used and aortic valve replacement was done. So I'm going to show you the device which is currently present in our Terminator. But before we do that, we just need to remember the fact that this could actually be coexisting with atherosclerosis at the root of the aorta. And then Harrison says that there could be fibrocalcific changes in the root of the aorta. See, what I'm saying is atherosclerosis of the root of the aorta could develop fibrocalcific changes, and this could involve the aortic valve. That is why you will see that in the later part of the discussion, I'll be talking about statins to be used in atherosclerosis. Obviously, we use statins in atherosclerosis, but the reason why they are prescribed in valvular aortic stenosis is in an effort to prevent the further degeneration of the disease. Because after all, first atherosclerosis will develop in root of aorta, then it is gonna involve the aortic valve, and subsequently the fibrocalcific changes will cause a calcification. So if we interrupt the disease process right in the beginning, the chances of development of this degenerative valve disease can be prevented. Cause number 3 will be, from Indian perspective, rheumatic fever. Isolated aortic valve involvement is definitely rare, but a combination of mitral valve lesion and aortic valve lesion is definitely encountered. So what I'm mentioning here is a presence of a commissural fusion, like in mitral stenosis I've spoken about commissural fusion. Similarly here also I'm saying Ashkoff nodules and the concomitant fibrosis that will develop subsequently can contribute to narrowing of the outlet and a concentric LVS developing. My next patient had a radiation to the chest. Let me say he or she was having a SVC syndrome due to Hodgkin's lymphoma. There was a massive alveolar lymphadenopathy, and he was having congestion all over the face, breathing difficulty as well. So when you are giving mediastinal irradiation, then the good news is obviously the lymph nodes will literally melt away. His SVC syndrome manifestations will become lesser. But in the same patient, after a couple of years, aortic stenosis can definitely manifest. Point number 5 again has a bit of a pediatric overlap, but still I'll mention about what is called as a Schoen complex. And because this condition is, I would say, a little rare, so all the way, I would say, more interesting from the pediatric domain. And one of the primary problems in patients who are having Schoen complex is a subvalvular. See, I began by describing the image also I showed you was of a valvular aortic stenosis, but what we are having here is a subvalvular aortic stenosis. So just you are comfortable with the fact that in tetralogy of Fallot, it is a subpulmonic stenosis. I'm teaching you Schoen complex. There's a subvalvular aortic stenosis present. Let's look at another very interesting feature which is present here, and you don't read about it anywhere else. And point number A is actually the reason why I have decided to speak about this condition, that is parachute mitral valve. So I have talked about a floppy valve, billowing valve, Barlow syndrome, that's MVP, but at the moment I'm talking about a different domain, a parachute mitral valve. Along with this, another feature could be present in these patients with respect to the mitral valve, and this, I would say, point number B again is important because we are talking about now a supravalvular. Earlier I was saying subvalvular aortic stenosis, now I'm saying there could be a supravalvular mitral membrane present in these patients, which will limit the amount of blood coming into the left ventricle of the patient. And the fourth problem in these patients is coarctation of aorta. So a bit of, I would say, heavy duty lifting for you guys, because just you are comfortable with tetralogy of Fallot and the 4 manifestations. Pentalogy of Fallot, again, I've discussed subsequently in congenital heart disease. A bit of extra work for you guys. Parachute mitral valve. Then a problem again above the mitral valve, that's a membrane. A subvalvular aortic stenosis and coarctation of aorta, these all things together present in a patient is what is referred to as a Schoen complex. And out of all of these, majority of the times in the exam, he's mainly going to talk about an old man, 60, 65, 70s, and there's a degenerative calcification with concomitant atherosclerosis in the root of the aorta. So the person will develop substantial amount of LVH, and therefore subendocardial ischemia and angina will be one of the reasons why these patients will come to you. I also want you to remember, since they love to talk about syndromes, I have said this earlier also, I am going to keep on saying this current statement that I'm writing right now multiple times in our discussion. The most common cardiac involvement in Turner syndrome happens to be bicuspid aortic valve, and after bicuspid aortic valve, again, yes, coarctation of aorta can also be present, but then this is percentage wise data. They simply put up the fact that it's a young female, she's having webbing of the neck, she's having a wide carrying angle, hypoplastic nipples, infantile uterus, streak ovaries, streak gonads, and what would be the cardiac aspect or cardiac lesion that would be encountered here. You all know this even from your pathology classes, a bicuspid aortic valve and also a coarctation of aorta. Now, once we know the causes, we are next going to talk about how the patient will come to you, how the disease will evolve. From the gender perspective, this disease will be more common in men as compared to women, and anyway, coronary artery disease is more common in men and women. And I said atherosclerosis could be one of the initial events, inciting events in the root of the aorta, following which aortic stenosis could be developing, though it can develop in isolation also. So don't be under impression that all cases of valvular aortic stenosis in old age are only due to atherosclerosis. I said this is a common association. It might be an isolated aortic stenosis also occurring in a person. Gender-wise data is about 2:4:1, and then when it comes to bicuspid aortic valve per se, then they have also documented important genetics behind it, that the pattern of inheritance for this could be autosomal dominant, and one of the genes which could be responsible for this is Notch1 gene. And you very well know the interest nowadays in genes is and especially chromosomes is tremendous. So wherever you read a gene, it's always a good idea to note it down. So what you noted down at the moment was Notch1 gene is related to bicuspid aortic valve. And when you will be listening to me in neurology, now obviously that unit is much more inferiorly located in the app, but when you will be listening to me for the topic of stroke, I am going to talk about NOS3 gene, but because they love to mix and match, various, I would say domains, cardio, neuro in a single question. So let's just try and remember this information also. NOS3 gene is responsible for a condition that contributes to small vessel stroke. The condition is called as cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. Longish name, don't worry. It's anyway present in stroke where I've written the full form, but this is a condition that contributes to small vessel stroke. So at the moment, 2 points to be remembered. That is NOTCH1 gene related to bicuspid aortic valve and NOTCH3 related to CADASIL that contributes to a cerebral autosomal arteriopathy, and there's a small vessel stroke manifestations which are occurring in the patient. Now, most of the time, the question will be describing 3 very standard features of these patients which can be understood or remembered by a mnemonic by the name of SAD. SAD here would mean that this old man, he's like retired from a bank, and he tries to maintain an active lifestyle. Like for example, he regularly goes to the market to purchase vegetables, and he says that I'm able to carry, let me say, 2 kgs of onions, 2 kgs of potato. Standard, people go to vegetable buy market from the market on the weekend. So he says, sir, I'm able to carry my bag. Till a recent couple of years, I was able to do all physical activity. I used to go to the market, purchase vegetables, come back, climb 2 flights of stairs. I was fit. But I don't know what's going on, doctor. At the moment, I start feeling dizzy nowadays. Whenever I try to carry a weight, there is a syncope on exertion. And the logic behind this is very simple, straightforward. There is a fixed obstruction in the outlet of the left ventricle into the aorta. So the cardiac output of this chap would be lesser. In fact, the orifice of the valve will definitely become lesser in severe aortic stenosis. So, though I'll be writing severe aortic stenosis criteria later on also, but at the moment I want to say one simple statement. Mitral stenosis severe is less than 1.5. Yes. Mitral stenosis severe is 1.5, very severe is less than 1, but in aortic stenosis severe is less than 1 square centimeter. To make the question look a little more technical, there is a possibility that he might write less than 0.6 square centimeter per meter square of body surface area, because obviously the height and build of everybody and body surface area of all of us is grossly different. So once the critical narrowing will occur, because most of the time mild to moderate disease might still be tolerated by the patient, but the same person who was fit and fine a couple of years earlier is now having recurrent episodes of syncope on exertion, like for example carrying a weight 2 flights of stairs. The second problem in this guy would be chest pain. Let's look at why angina episodes would be occurring. And though I have said it verbally, what I'll try to do here is draw a quick line diagram so that we can be on the same page to understand the problem. You see, what's happening in this patient is a substantial narrowing of the orifice of the aortic valve. So the left ventricle will have to generate more pressure to send blood into the aorta. For generating more power, you need more muscle. So what happens in all of these patients is a concentric left ventricular hypertrophy. Now the good news is obviously the blood will be able to go out, though the amount of blood will definitely be lesser because the orifice is less, but at least some output is being maintained in this person, and therefore because the demand of the muscles is more, coronary artery supply is going to be same or can even be having a narrowing. You see, in old age and even narrowing of coronary arteries will be occurring. I'm saying even if you rule out that factor, even if you say, sir, his coronary arteries are of perfect caliber, even then because the demand of the heart here is increasing, so there's a mismatch between the demand and the supply. The demand is more, supply is normal or can be lesser due to atherosclerosis. So that's why I've written angina in these patients. Angina pectoris like pain, especially on exertion, would be developing. And in multiple choice question, obviously, he may not write the word angina, but he might just describe this mismatch between the demand and supply by writing subendocardial ischemia in these patients. The third feature that will develop in these patients would be dyspnea. So let us understand why breathlessness is occurring. Agreed that in all cardiac cases, ultimately if left side of the heart is involved, dyspnea will occur. But what is happening in these patients is that because of the hypertrophy of the left side of the heart, the left ventricular end diastolic pressure will be increased. If the end diastolic pressure is increased, if the left atria has now to send blood into the ventricle, it will have to do more work. So I'm putting a double plus here sign to say that in this particular case, this elevated left ventricular end diastolic pressure will mean that even the left atria will have to generate more force. And since I'm increasing the pressure gradients here, so definitely this pressure gradient will also be transmitted to the pulmonary circulation. Mark my words there. I'm not saying that there is any pooling of blood due to backflow blood. No, I'm not talking about any backflow blood. All I'm saying is the pressure gradients will keep on changing because the heart has to ultimately get filled with blood. So here the chances of getting filled with blood will be relatively reduced because the end diastolic pressure is elevated. So the LA has to work harder, as a result of which the pressures in the pulmonary circuit will also increase, and therefore they would be pooling of blood in the lungs, but not due to any regurgitation like it occurs in mitral regurgitation. I'm not describing at the movement either MR or AR. I'm talking about aortic stenosis. There is a diastolic malfunction. There's a diastolic problem in this patient which contributes to the pulmonary edema, and the exercise intolerance of this patient. It's already exercise intolerance coming up right now because of the syncopal episodes. It will start worsening in these patients because if at this point of time he does not seek medical treatment, then subsequently the pulmonary artery hypertension component will also develop, because I said the dyspnea component is because of the pulmonary edema. There is pooling of blood in the lungs. That's a very casual way of saying pooling of blood in the lungs. Actually, it's a diastolic malfunction which is contributing to the pulmonary edema component. Long-standing pulmonary edema will cause PH. Now, if there's a long-standing PH, then even the right side of the heart will get involved. And if the right side of the heart will get involved in these patients, then what will be the manifestations that would be written? One problem in this patient, he will just say, exercise intolerance of this person has worsened. Earlier, he was saying, I was having problems in climbing flight of stairs. Now he's not talking about climbing stairs. He's saying, sir, even going to the bathroom is a Herculean task for me, or a difficult task for me. His ability to perform has even reduced. Physical activity has substantially reduced because long-standing pulmonary edema can contribute to PH. In fact, due to PH, another problem can occur. Right ventricle will begin to dilate. And if the right ventricle will begin to dilate, then I can say this chap can also develop a functional tricuspid regurgitation. You see why I'm saying functional tricuspid regurgitation? Because there is no problem with the valve leaflet. Caudate and DNA are fine, valve leaflets are fine, but because the tricuspid annulus will start getting dilated because of the right ventricular dilatation, so there could be a TR, and the importance of this is that TR can contribute to a pansystolic murmur. Guys, the surprising thing that I'm teaching you is that in valvular aortic stenosis, there's going to be turbulence when the blood is going out of the heart into the aorta, and this produces what is called as a ejection systolic murmur. And in the condition which is traditionally studied by us as having a ejection systolic murmur, I taught you there can even be a pansystolic murmur. Let's go back and have a look at this again. The murmur of this condition is ejection systolic murmur. In fact, the murmur can be so loud that it might even be radiating to the carotid arteries. So therefore, you will always read the word carotid thrill. My point is that this is traditional information. The one in blue, you all know about it even before you came to this lecture. But what I want you to understand is that there is a possibility that in the exam, he might want you to think one step ahead, that is in long-standing aortic stenosis, as the severity of the disease increases and the patient refuses to seek medical care like it happens in India, no big deal, that the person could end up with a dilatation on the right side of the heart subsequently, and that can cause a functional TR, and even a pansystolic murmur could be written. In fact, he could even write a hepatomegaly. Now, the points that I've said right now, which I'm just highlighting at the moment: exercise intolerance worsening to the level that going to the bathroom is a big problem, suggestive of pulmonary artery hypertension, pansystolic murmur due to functional TR, hepatomegaly. These are all very late features, but can be present in a question because we are talking about left side of the heart. So we usually tend to neglect findings with the right side of the heart, like for example hepatomegaly, but yes, it can occur in patients of valvular aortic stenosis. The traditional murmur that is present in this patient would also be called as a crescendo, decrescendo murmur, because the intensity will rise and fall. And subsequently I'll hand draw the murmur configuration of the shape here before you as well, but this is how the disease usually evolves. And most of the time the age group of the patient will be given as like 65-70, though if he wants, obviously he can talk about a pediatric disease also, in which case it will not be calcification, then it's gonna be a bicuspid aortic valve or a malformed valve or a unicuspid aortic valve. That's his choice whether he wants to write UAV or a BAV for you in the question. Let us now focus on the examination findings that you will be encountering in these patients. So you could be having hypertension. Now the query from a lot of you would be that, sir, on one side you are saying that the person is having a fixed obstruction due to which less blood will be going out of the heart, then this person should be having a low blood pressure. I agree to that. You see, what I'm simply saying is that hypertension could be a concomitant condition, because I'm talking about geriatric age group, so there is anyway hardening of the blood vessels. So this could be a concomitant coincidental hypertension present in this guy. This is not due to the valvular lesion per se, it's just a lesion which will actually put even more stress on the heart because it will worsen the left ventricular hypertrophy. So the message is, if somebody is having isolated aortic stenosis at a younger age group, like in pediatric age group, then definitely the blood pressure values would be lesser. But because I was mentioning a geriatric age group patient, so I have mentioned hypertension here as well. The next finding will again explain to you that why I explained all this is because if I would just write that the pulse pressure is low in these patients, you will say, sir, on one hand you are saying hypertension, on the other hand you are saying pulse pressure is low. The reason why I've said pulse pressure is low is because in this condition there is a fixed obstruction, so systolic blood pressure will anyway be lesser. So when I talk about isolated aortic stenosis, pulse pressure will definitely be lesser, and because of this obstruction the pulse will rise slowly. As compared to a normal rate of rise, the pulse rise will be slower. So therefore the pulse which is present here is written as pulsus tardus et parvus. That's again a very characteristic term that we read, and this is discussed in the heart sounds discussion as well. The alternative name for this slow rising pulse because of the physical obstruction would also be called as anacrotic pulse. So either of the two terms can definitely be asked. And a related MCQ that I'm saying is dicrotic pulse, D for Delhi. Dicrotic pulse is seen in dilated cardiomyopathy. Again, this is discussed in the heart sounds video in the initial part of the app, that is heart sounds 1, 2 and 3, but I've just highlighted the names once again. Then when I have evaluated the apex beat of this person, I have noted that the apex beat is heaving in character. Heaving would mean that the apex will be so forceful that it will lift your finger, and this is again because of the hypertrophy. And apart from this, the apex beat will also be displaced. Normally apex beat will be 2 cm medial to the mid-clavicular line. In this chap, it's gonna be displaced further to the left. And then a very characteristic finding that you encounter in patients of left ventricular hypertrophy who later on develop a left atrial hypertrophy also, that is a double apical impulse. You see, one, I said the apical impulse in this patient will be displaced. So there's a possibility that you might be able to feel the apical impulse of this person in both the 5th as well as the 6th intercostal space. So the apex beat area will definitely become diffuse and it will be heaving in character. But meaning of the word double apical impulse is that there is a left atrial hypertrophy also. So double apical impulse, why does it come? If he says what is the cause for a double apical impulse, there are two aspects. One, I said it's gonna be much more diffuse, primarily because of the fact that it could be felt over 2 intercostal spaces. But if he says what is the reason for double, then this is the forceful LA contraction which will be occurring against a non-compliant, AG here means against a non-compliant or a less compliant left ventricle. You very well see that the person was having lot of hypertrophy of the concentric variety, and the extra muscle is not going to add extra power to the heart. Rather, it is going to interfere with the filling of the heart. It's a bulky heart. It's going to get, it will have problems in getting filled because of elevated left ventricular end diastolic pressure. And therefore, I've used the word non-compliant left ventricle. So you are here feeling two impulses. One impulse is obviously the left ventricle contracting, and just before S1, it's the atria that is also contracting. So that forceful atrial contraction against a non-compliant left ventricle is responsible for a double apical impulse. Whenever blood goes through a narrow area, the velocity increases. This increase in the velocity of blood can be so much that this turbulence can be transmitted even to the carotid artery. I'll just show the handmade diagram again to you. This is what I said. I said because the orifice is narrower, there's a concentric hypertrophy of the heart, so the combination of the two will increase the ejection velocity. Total amount of blood going out is less, but velocity is definitely higher. So this velocity of turbulence can be actually palpated, because any murmur that is palpable is called as a thrill. So no big deal. When you read the book, it will say carotid thrill appreciated, very good pickup point in a multiple choice question, and under no circumstances ever should you miss it with dancing carotids. You all know from reading Hutchinson and other clinical books that dancing carotids is a feature of valvular aortic regurgitation. That's again discussed in the app also subsequently, but carotid thrill is a very good pickup point to pick up a presentation of aortic stenosis in geriatric age group. What we will do next will be talk about the second heart sound in these patients. And one of the important findings in these patients would be that because the obstruction is present in the heart, the blood is going to take more time to go out of the heart. If blood is going to take more time to go out of the heart, I said more time required. Therefore, aortic valve of this person will close late. If the valve will close late, the auscultatory finding and has been discussed even the heart sound section is narrow split second heart sound, because traditionally this split is approximately 30 milliseconds. You see, P2 component will keep on varying with respiration, but it is the A2 component which is getting delayed because blood will take more time to go out of the heart because of the physical obstruction. And if the same person does not take treatment, the gap will become even more narrow. There's also possibility that the two will superimpose. So no big deal that instead of writing a narrow split second heart sound, he might say a single S2. Or for that matter of fact, there's also possibility that it might overshoot. You can see I've drawn a very thicker arrow to highlight that the pulmonic valve will close on time. It can definitely vary with respiration because there's no problem on the right hand side, but the aortic valve will close so ultra late that it will close after the P2. So the configuration will be written as P2A2, and because P2A2 is grossly opposite to normal, so he's going to use the word reverse splitting of the second heart sound. So whenever you read these terms along with presence of a carotid thrill, I think the diagnosis is relatively easy to pick up. And also fourth heart sound will be heard in these patients. Reason for fourth heart sound will be a left atrial hypertrophy that will develop because the atria is having to work against a non-compliant left ventricle. Now let's look at the murmur that we'll encounter in these patients, and this would be a systolic murmur. The intensity of the murmur will rise and then will decrease. So when you read Davidson, he uses the word crescendo, decrescendo murmur, but that's a very longish name. So in multiple choice questions, they are simply going to use the word ejection systolic murmur. This ejection systolic murmur can be appreciated well in the right upper sternal border and will be showing a radiation to the carotid artery. So a very important diagnostic feature anyway, and even if you don't remember it, I said carotid thrill will do the job for you. The next statement that I make has to be listened with care. There are two aspects with respect to a murmur of aortic stenosis. Aspect number one is the opening is narrow, so there is noise. You see, any narrow opening, liquid will go, noise will be produced. So the first star mark that I put here is primarily for the noise due to the narrowed opening. But the second point that I'm saying is that when the blood will be traveling through this narrowed opening, there will be setting off, or it will be setting off vibration of the valve itself. You see the valve tissue, it is still having some amount of compliance present. It's not stiff, right? I agree it is a calcification, but still it is a pliable valve. So there would be some vibrations that would be set up, and these vibrations of the valve leaflets by themselves, the noise of these vibrations tends to radiate to the axilla. I repeat my statement. I said the turbulence of the blood ejecting into the aorta will radiate obviously to the carotid, but the vibration of the valve leaflets, the noise that is created, this can radiate to the axilla. And there's one more finding that you always study in medical college, and I've also taught also, that murmur of mitral regurgitation can also radiate to axilla. So there can be confusion for any doctor, that he might think that what he's hearing as a sound coming towards the axilla of the patient is murmur of MR, or is it finding of valvular aortic stenosis. stenosis. So obviously other findings are going to help you in identifying MR versus aortic stenosis, and if you are not able to find out, you anyway have a echocardiography at your disposal, which will make life easier. But still, because of the fact that this is a point which can cause confusion for a doctor, so therefore they have marked it in the book as Gallivardin phenomenon. The message is Gallivardin phenomenon. The sound which is radiating to the axilla, it could be either due to aortic stenosis or it could be due to mitral regurgitation. But here it is the vibration of the valve cuffs which is contributing to this. I'll be next explaining to you regarding the workup of this patient. So the first and the foremost investigation that I can do is the ECG. And one of the important diagnostic criteria for left ventricular hypertrophy that would be occurring in this patient would be that you will first check out the depth of the S wave in lead number V1. To this, if you add the height of the R wave in either lead number V5 or lead number V6, if this turns out to be more than 35 mm, this is suggestive of LVH. So let's just practice it here in this particular ECG of this patient as well. So you are first noticing the depth of the S wave, and I'll just put numbers there. I can say it's definitely more than 4, but at least 4 large squares can be made up. So this would be about 20 millimeter. Now let's focus on the V5 component, and you can notice that the height of the R wave is substantially tall. So I'm just going to put some numbers here once again. This would be definitely, I would say, around about 5. So if you add up the mathematical value here, this would be 20 plus 25. This will be 45, whereas the cutoff that I gave you was something in the range of 35. So this is suggestive of LVH. Though best way to identify hypertrophy or chamber enlargement is always going to be echocardiography. But because they can ask you this diagnostic criteria, I have just mentioned it. When I'll be doing a chest X-ray, I will notice that the cardiothoracic ratio will be increased by more than 0.5, in pediatric age group more than 0.6, and even the apex of the heart will be displaced inferolaterally. The best way to confirm the diagnosis will be transthoracic echocardiography, which will not only confirm the diagnosis but will also help me know whether it is mild, moderate or severe valvular aortic stenosis. And majority of the times mild to moderate may be tolerated by a person, especially if he's having a, I would say, athletic background. Like let me say this old man, 70 years of age, had retired from the armed forces, so he was anyway having a good physical health, so he was able to manage through the mild and the moderate phase. But as the disease goes into severe, then there's a progressive deterioration. So for mild, the cutoff to be remembered would be 1.5 to 2 square centimeter. Moderate would be in the range of 1 to 1.5, and severe would be less than 1. And I would like to remind you again, for mitral stenosis, severe is less than 1.5, and less than 1 there is not severe, it is very severe. Now, because this person is having chest pain, especially on exercise, so you might be tempted to do a treadmill test in this person or a stress echocardiography in the person, because you are thinking he could be having coronary artery disease also, which I would like to pick up. But treadmill test and stress echocardiography is absolutely contraindicated in a patient of severe valvular aortic stenosis. Even when I have subsequently talked about the topic of chronic stable angina, I have highlighted this statement that in CSA patients, though there are a lot of contraindications to treadmill test, like if somebody is very fat, he can't be expected to walk on a machine. If somebody is having Burgess disease, somebody is having non-healing ulcer on the sole of the foot, he can't be expected to walk on a machine. But absolute contraindication to a treadmill test is the condition that we're studying, severe valvular aortic stenosis, because here the cardiac output is critically narrowed. If you make him walk on a treadmill, he will lose consciousness, bang his head against the railings, end up with a head injury, which I obviously don't want. And obviously medical legal cases is something that we all want to avoid. So how am I, in this old man, be able to identify that yes, there is a problem in his coronary arteries? Because at 70 definitely it could be present. So I'll be more comfortable suggesting to this person that, sir, we would like to do a coronary angiography in you, and if we find single vessel disease, we'll put in a stent. Double vessel disease, we'll put in a stent. We'll do a balloon angioplasty and do stenting. But if it is triple vessel disease, then we will recommend you to undergo a coronary artery bypass grafting. So the main objective would be of the coronary angiography will be that we would like to pick up fixed obstruction, but this time the fixed obstruction is not in the valve, but this is fixed obstruction in any one of the coronary artery or arteries of the patient. The fifth investigation that I can do in this patient is a chest CT. Now, whenever I have discussed a valvular lesion with you, I have always talked about echocardiography, but this is the first time that I'm introducing a chest CT. You see, the advantage of a chest CT will be mainly that it will be not only able to pick up a calcification, but it will also be able to help you in anatomical reconstruction of the aortic valve, because you see, there were a lot of causes that I explained to you. So before intervening in the patient, I definitely would like to know the exact anatomical defect present so that we can take appropriate action. So anatomical reconstruction can be done, and nowadays we can also do a cardiac MRI. In fact, if in a question he says what is the best way to identify valve defects, echo is also given and cardiac MRI is also given. Then current scenario, it is cardiac MRI. With cardiac MRI can scan, especially if surgical intervention has been done in the valve also. So the valve was a congenitally malformed one, surgical intervention was also done, and maybe that congenital malformation, when it was treated, there was an overcorrection. Aortic stenosis was treated and patient developed aortic regurgitation. That can also happen, no? Overcorrection can occur. So if I want to identify what really is the current status of the valve, is it stenosis? Is it regurgitation? Is it a combination of the two? You would have seen so many cases in your ward where it is written AS with AR. Because if the door will have problems in opening, it will obviously have problems in closure also. Here I'm discussing valves lesions in isolation because this is the first time we're reading it. But once you have listened to AS and AR, you will realize that no big deal. You could be having a combination of the lesions in the question given as well. So for anatomical reconstruction of the valve, it is valve anatomy per se, yes, cardiac MRI will be sufficient, but yes, considering resource limiting settings, we can do a transthoracic echocardiography to identify valvular lesions. Now, if these patients are not treated, once they have become symptomatic, then death can also occur. So I'll just put in some data here before you. You see, let us assume that at the moment the symptoms of the patient are mainly syncopes on exertion, and he has also started experiencing anginal episodes. So if he is not gonna get treated, then these patients will usually die within 3 years of symptom onset. These 3 years that I mentioned is with respect to symptom onset. Like if the symptoms of the person develop by 2021 and he is not seeking proper medical care, the guy would be dead by 2024. If dyspnea has started developing in the person, that means there is the left ventricular end diastolic pressure increase, then the chances of this person dying will be much faster. He will die over the next 2 years. But if he has developed congestive heart failure features already, then in those circumstances this person would be no more by next 1.5 years. And well, I would say that you all need to remember here is, because the question that will come up will be that which of the following conditions in a patient of valvular aortic stenosis will the patient have the highest risk of dying? Your answer would be congestive heart failure. And well, I can just say, when I say the word congestive heart failure, it looks a very scary statement. No, heart is one of the important organs in the body. When you tell somebody your heart is not working, he's obviously going to throw a panic reaction. Sir, what are you saying? Heart failure? So heart failure is gonna be the most important, I would say, feature which tells you the fact that it's very late for management of this patient. In fact, interventions have to be done, decision making has to be faster, otherwise this guy will be no more. So now let's look at what are the interventions that we'll be doing in this person. And apart from obviously our transcatheter aortic valve replacement, which our dear Arnold Schwarzenegger underwent, let's have a look at what other aspects need to be handled. You see, since hypertension will be coexistent in these patients, so ACE inhibitors need to be started, but you need to titrate the dosage of ACE inhibitors, because you see, if somebody is having isolated aortic stenosis and then subsequently he starts developing hypertension, there are two problems in the person. One problem is low cardiac output, second problem is peripheral resistance is more due to high RAS system. So you're trying to neutralize the high RAS system, but when you give ACE inhibitor, it can cause hypotension also, no? And this guy is already having a low cardiac output. So you need to use the drugs very judiciously. Start at the lowest dose possible of ACE inhibitors. If required, use beta blockers, but start at the lowest dosages of each one of these and then titrate upwards. If a person is having severe aortic stenosis, I would recommend these patients to not participate in any kind of athletic activity, no competitive sports for these patients, because they will not be having the capacity to increase their cardiac output. I mean, something as simple as cycling. In old age, you will see people doing cycling or a bit of jogging. I mean, if this person is doing any strenuous activity, there could definitely be a mishap developing. Also, I would not suggest these patients to, especially jog in a hot Indian summer outside, because if they are having lot of sweating and they get dehydrated, then the problems will double up, because you see already there's obstruction in the heart, and if due to dehydration, even the circulating fluid volume is less. If the total blood volume is itself less and going out of the heart is also less, the chances of these patients dying will definitely be increased. We have also prescribed statins to these patients because they're having risk factors for atherosclerosis, but studies at the moment have been disappointing with respect to the perspective that they have not changed disease progression. So we give statins, okay, for atherosclerosis, for risk factors, for deranged LDL values in these patients, but statins have not been, I mean, if somebody is having established valvular stenosis and he says, sir, when you will give me this medicine statin, I have read that it will reduce atherosclerosis. Yes, I mean, atherosclerosis reduce means it will reduce the progression. Whatever atherosclerotic plaque is present, that's not going to reduce or reduce minimally, but it is the progression of the disease that will reduce. And as such, statins can be given in these patients, but they do not change the progression once calcification has occurred in the valve. Now, before I mention about the treatment part, what he will do is that in multiple choice question, he will write various stages with respect to aortic stenosis, severe variety, or he will say moderate aortic stenosis. So let's look at these stages also. I'll start with the stage D. It basically means that the person is having severe aortic stenosis and he is symptomatic. And the sad mnemonic that I mentioned before you, syncope, angina, and dyspnea is very much present. But let us assume a person who's having severe valvular aortic stenosis, but at the moment he has not become symptomatic, so we will categorize him as stage C. On the other hand, if person is having risk factors for atherosclerosis, like he's a smoker, he's a diabetic person, he's having a coexistent hypertension. So if risk factors are present for a valve malfunction, because you have to understand here, I said risk factors for malfunction as atherosclerotic risk factors like smoking, diabetes, because atherosclerosis in the root of aorta can progress and involve the valve, and as the lesion keeps on increasing, there is a calcification not only in the root of the aorta but even the valve per se. So if risk factors are present for valve malfunction, then definitely that would be stage A. And if a person is having mild to moderate aortic stenosis, which was maybe detected on a annual medical checkup, like you see nowadays health awareness has increased post-COVID. So there is a possibility that, an older man, especially 60s, 70s, they're coming for an annual medical checkup, they've taken insurance, and you detect it on echocardiography, but this chap is asymptomatic at the moment. So we will classify him as stage B. Now, when would you intervene? So MCQ wise, you need to remember, if a person is in stage D, then a transcatheter aortic valve replacement will be done. So what we are going to do is not open the heart of this patient, but what we are going to do is deploy a new heart valve in this patient, and that is what Arnie underwent. That is a TAVR, a transcatheter aortic valve replacement, and we are going to go by the femoral artery of the patient, go retrogradely, deploy a new valve. The old valve will remain its place. The old valve will be pushed backwards, and it will help in securing this new valve, which will be able to function properly. So in stage D, it's a TAVR which is to be answered. Now suppose, it's a technical aspect that I'm saying subsequently, suppose it talks about stage C in a patient. Now this chap is having severe aortic stenosis but is asymptomatic. So I will here take into consideration some other aspects also, like for example, I'll take up and calculate by echocardiography the ejection fraction, which is turning out to be less than 50%, and similarly I'll also calculate the ejection velocity. I told you that whenever the orifice will be narrower, the liquid will travel with more turbulence. So the ejection velocity will definitely be increased. So if echocardiography report says ejection velocity of more than 5 meters per second, in your and my heart, the ejection velocity is 1 meter per second, 3 feet per second, 1 meter per second. That 1 meter is equal to 3 feet. Here it is 5 times 5x of normal. And then there is a increased transvalvular gradient also given. What I mean by transvalvular gradient here, and that's important for you to understand, is this is the pressure difference between the left ventricle minus the aorta, because after all the left ventricle is working against a resistance. So LV minus aorta pressure gradient, if this is more than 60 millimeters of mercury, it means the fact that this guy also needs to undergo a transcatheter aortic valve replacement. The learning for you guys is that even if you don't remember the technical aspects I said here, the message is even in an asymptomatic chap, we would like to go in for intervention. One advantage of this intervention is that we are not opening up the heart. It's not open heart surgery like in earlier times. It's a transfemoral approach. Patient can be discharged maybe the same day or the next day. So the hospital stay is also relatively lesser. So we are now more aggressive with respect to treatment of aortic valve disease. Earlier times we used to let the dictum was let the patient earn his surgery. Let the patient, if I say let the patient suffer, it will look a little unethical. So what I'm saying is let the patient earn his surgery. I mean, when he will develop the disease, when he will suffer, we are going to intervene. But now the approach is that if this guy is detected earlier, he is asymptomatic, severe variety of aortic stenosis, echocardiographic criteria mentioned here, we would still like to go in for intervention for these patients. So these are a couple of aspects, guys, that I would like you to remember for this topic. Valvular aortic stenosis is a fabulous, I would say, fantastic lesion to actually understand the hemodynamics of how a systolic lesion can affect even the right side of the heart and can even cause a functional tricuspid regurgitation. So I mean, this lesion per se gives you a better insight into the operation of the heart and how in spite of that limitation of the orifice, you know, it's reduced to 1.5 square centimeter and still the person is asymptomatic. So you can understand how resilient this organ is also, and therefore, I mean, it's going to ensure survival. So these are the technical aspects, guys. Keep hammering, keep the focus on, keep learning new things every day, and you will definitely grow as great doctors. Take care. Bye-bye.